and see you virtually again. So my topic today is actually antiarrhythmic drugs, which goes along with the one of the objective of the course to learn about arrhythmias and different type of treatments, of which pharmacological agents are one of the option. So thank you, Cecilia. So what I'll do is I have to acknowledge that this talk was originally given many years in this course by our cardiology pharmacist, Carol Cherise, whom recorded a previous lecture before, as well as Sintra. And so because of a different schedule arrangement and because of my ICU experience, I'm also requested to share our experience through the slide deck and the talk today. So I need to acknowledge their contribution. A lot of the content are built on their work. In addition, today I've included some of the key salient points about practical monitoring of therapeutic drug monitoring aspect of these drugs and want to share with you. So I want to give credit for our Erin Chung, our therapeutic drug monitoring coordinator, who have done the background in terms of trying to advocate for TDM drugs in-house in terms of levels. So I'll share with those information. You should have a slide deck. And with the recent literature update I've just performed to prepare for this talk, I've included some key references at the back of the slide deck that you're welcome, obviously, to do your own primary lit search. But I find those key references are good sort of landmark papers for you to sort of gain an idea or overview or refer to. Okay, so with that, there's nothing to disclose, okay, from my perspective for all the content here, as well as the previous pharmacist slide deck information and my updated information. Objectives for the day is review mechanism of action and use of antiarrhythmic medications by arrhythmia type. Now, I have to actually disclose that I'm no expert on reading ECG or arrhythmias, interpretation, or sort of the overall treatment. However, the pharmacological actions and the efficacy, side effects, and tips to use that's something that I want to focus on as pharmacists to share with you today. And overall, the whole course, you can refer back to the content today and sort of put them into relevance in practice, as you cover different type of arrhythmias by different experts in the course that Cecilia already mentioned. So we go by this Vaughan Williams classification of antiarrhythmic drugs. And to me, I draw a lot of analogy with antiarrhythmic agents and anti-seizure medications because they all deal with electric signals, action potentials. Here's with the heart, whereas anti-epilepsy drugs would be, geared towards neurological neural cells, sort of action potential. So we need the Vaughan Williams classification to give us some analogy or some classification system to know when to use what class of agents and within which agent of that class, to have some common communication language, as well as knowing sort of in general what are the major mechanisms of action and how to use that. Describe ECG change associated with various antiarrhythmic agents. Again, I'm not ECG experts. However, there are some common ECG changes that's part of the pharmacological action. That's why you're using them to treat certain type of arrhythmias. But it might extend to side effects of these agents because of those ECG changes, initiated or instilled by these agents based on their classification and how they act. So we will also review considerations and pharmacokinetics for pediatric patients' context with these agents and mention dosing, adverse effects, and administration of selected antiarrhythmic agents. Now, I have to tell you that the purpose of this lecture's slides is not to replace a primary lit search studies, nor a good tertiary reference to check dosing. There will be up-to-date online references that it's available, but just to highlight some of our practical use of these agents in the context of pediatric critical care or pediatric cardiology care, but sort of highlight the sort of a tertiary review, but then adapt to how we use it. Okay, all right. So why do we use these drugs, and what is the goal? I mean, just like antibiotics, your goals might be to cure an infection. Here is to restore synchrony to myocardial contraction. You obviously wanted to suppress abnormal rhythms so that we can get back to normal sinus rhythm and where the heart can coordinate the contraction, ultimately provide a effective cardiac output to support the patient's function. So reduce heart rate, at many cases to reduce the heart rate to maintain cardiac output. And perhaps so those patients might be as a bridge using medications to ICD, radio frequency ablation, and other type of procedures or non-pharmacological treatment. So it's really a bridge to sort of stabilize the patient. So how do the antiarrhythmics do these goals or achieve these goals? Through general mechanisms. Each drug within each class is unique, but in general, they reduce the conduction velocity of the conduction fibers, so they're not sort of, giving odd beats, not synchrony to the pacemaker. So reduce conduction velocity so that, the sort of the pacemakers can continue to be the pacemaker. And reduce automaticity of the pacemaker cells, not necessarily at the node, but, pacemaker cells around the node or other pathway, and increase the refractory period. Okay, so that the heart has a chance to restore synchrony. So that's how it achieved the goals. Okay, and keep in mind, these antiarrhythmics might be working in synchrony with each other or synergistically with each other, and with, other non-pharmacological devices like a pacemaker, with other modalities. Okay. Let me just show you. I think you know better than I do about this action potential graph. Okay, so it's in your slide, but my point of including that is, one, is complex. Okay, you have what you see or detect electric currents and describe an action potential when a cell fires, but then it sort of translate to the heart conductivity to your ECG. So it's a very complex, almost like a 3D extrapolation of what happened at the cell electrolytes level to what you see from ECG, trying to guess what's going on outside of the patient, looking at the graph of the ECG. And the drug works by different phase, okay, of the action potential. Okay, you will see that there's some sodium channels active agents, there's some calcium active agents, there's some potassium active agents, but there are also broad agents that works many different ways and many different phases. So just to keep in mind, there's not a simplistic explanation, but we're trying to apply some general understanding or rules for a very complicated class of medications. Okay, all right. So I'm not going to repeat what Cecilia and others said, but keep in mind that by working at different phases of the action potential, it will translate into changes in the ECG. We talk about prolonged QT interval. We talk about some of these P wave or the affecting of the refractory period. It all impact on what you see visually on the ECG and what's going on in the heart and the channel. Okay, so let's focus on the drugs. Okay. So rather than fancy graphics, I'm going to show you all the points here. So in general, to make sense of these complicated class of drugs, we classify the von Williams classification into 4 classes. Keep in mind that there's some broad spectrum agents that cross different class. The first class is the sodium channel blockers, and I'll go into each class and subclass in detail later after the slide. 1A is sort of like your family within family. You have prolonged refractory period agents. And then the subfamily of class 1B is no change or just shortened refractory period. And then you have a class 1C, which is mild prolongation of the refractory period. So even though they're sodium channel, they act on the sodium channel. But like any siblings in the family, they have different abilities or talents or your sort of behaviors. So A is prolonged, B is no change or shorter, and then C is, mild prolonged, so somewhere in between. Then you have your class 2 agents, which we are familiar with to use it for a different indication or context. These are beta blockers, beta adrenergic receptor blockers. So in most common sort of contexts, we think them as antihypertensive agent or hypotensive causing. But here, they are different. They're used for the context of antiarrhythmic agents. Then remembering your action potential, then we have those potassium channel blockers. Again, the overall general class agents prolong action potential, duration, and refractoriness. Okay? Then you have your calcium channel blockers, which again, it ties back like beta blockers. They also use in the context of antihypertensive agents, but here's again, focus on its action on as antiarrhythmics. Then you have drugs that actually don't belong to any of these classes. They are adenosine, digoxin, magnesium, and even dexmedetomidine, which I've added for this year's slide as well. So they don't really belong to the older classification, but they are there to use. It's like different tools in your toolbox. So what's the general concepts, okay, in general, so that we can remember that? And of course, when you need to learn about that, there is proper reference for you to read deeper into it and refresh your memory. This is just an overview. General concepts. So class 1A, which prolongs refractory period and increased repolarization time. Same for class 3. I mentioned it up there. Prolonged action potential and refractoriness. So they sort of like work together even though they're different families. They also increase the QT interval and perhaps increase the risk of torsade points. So those are 1A and 3. So there's like friends, although they're different families, they're like friends and they work similarly. Okay? They work differently, but the outcome, the effects are similar. Class 1B, it only focuses on its work on ventricular tissues, so they might not be that effective, and typically they're not used by prescribers to treat AFib or A-flutter, okay, the atrial type of arrhythmias. Now, this is only general, okay? I want to caution you that it's almost every case is unique congenital heart defects or anatomy or post-op complications. So this is general and you have to individualize. I think the beauty of this course is help you to know the general, but also help you to understand how to individualize, okay, for our patients. Now, class 1C is pretty useful, but it's not recommended in heart failure. And unfortunately, a lot of our patients, post-op cardiac patients or heart failure patients, they have heart failure and arrhythmia is sort of either generated from the heart failure or it's sort of a comorbidity of coexisting with the heart failure or severely reduced left ventricular function. The CAS study on the adults showed increased mortality, so there's a bit of hesitation using 1C. However, in our context, we use 1C pretty regularly, and we'll come to see why. Class 2 and 4, the remaining classes or families, they in general decrease heart rate beta blocker, calcium channel blockers. We know that from our antihypertensive indication. And therefore, because the decreased heart rate, that's the probability, and that's why we're using it, it may cause bradycardia as well. It affects the force of ventricular contractility and it prolongs the PR interval and may even cause second and third degree AV block. I know that Cecilia was talking about heart block, and I'm sure that in future lectures we'll talk about that. Okay, next. So class 1 agent, just bring you back to memory. These are the sodium channel blockers, okay? So just so that, okay, sorry. Okay, so it's sort of, membrane stabilizing property. Just know that by stabilizing the sodium channels at the cell membrane, it increased the effective refractory period. So they're more stable. So they're not firing just by that reaction. So it makes cells harder to depolarize. It inhibits sodium influx, so that's why they call sodium channel blockers. It blocks sodium coming in, so that sodium is not influxing and triggering this action potential. It's stabilized, so it's not firing all the time. How does it work? It blocks the sodium during phase 0 stroke of action potential. I have a diagram in the beginning, but I don't want to flip back like 5 slides before, but you have it in your notes. So focus on phase 0 and decrease phase 0 depolarization. So it's sort of like harder to go up. So the slope is less steep, so it's harder to go up and fire and cross that line. So that's what it means by blockade of phase 0 upstroke. The bottom line is it prolongs refractory period in the Purkinje fibers, and overall it achieves the goal of decreased automaticity. Now, how does it compare to the siblings in class 1B and 1C if we now talk about 1A? Is 1A have a moderate blockade okay? Whereas B and C, you'll see how they differ. Okay, so 1A, what are we talking about? What medications are we talking about? These are not agents that we use nowadays as often now. Quinidine, it has more side effects, especially GI, and disopyramide. Okay, it still exists in our formulary, you can still get it, but it's sort of, come into a different phase or perhaps a refractory cases or second line. And again, I have to say that you have as many papers, could be different quality of papers out there to prove one or the other. It then becomes a unique composite of your center's experience with different post-op cardiacs, congenital heart defects or arrhythmias, and your core group of prescribers, their own collective experience. So quinidine has more side effects. It is very much dependent on liver flow and liver metabolism. And relatively younger patients might have requirements of higher dose per kilo. And it does have more side effects in terms of CNS and proarrhythmias, okay, and hypotension. GI effects very common, and even blurred vision, tinnitus, headaches, GI upset, thrombocytopenia. So you can see why people are now moving away for other agents when they might perhaps have a wider range of efficacy and tolerance of side effects. Disopyramide, very, very similar in the fact that we sort of don't use it that often. It has anticholinergic side effects. That's not desirable. It decreased left ventricular function. That's more like a negative inotropic effect. So that's not really good for your heart failure patients. Post-op, or which is acutely, or sort of a chronic, the heart failure patients waiting for perhaps a ventricular assisted device or waiting for a heart transplant. So I want to include though, now a more popular agent with this class A, 1A, is procainamide. We still use it. It decreased myocardial excitability, so calm the membrane down, sort of really slow down the conduction velocity, which is a class common effect. It does have anticholinergic and local anesthetic effect as a canamide, right? Indications are listed here. And again, when you go through the course of these indications, you will see how these drugs are used in that specific indications or type of arrhythmia. Tosor, because it increased QT, hypotension. Now, the GI side effects is more like, common and it could be managed, but it may affect compliance as well as the oral absorption. But the more serious one that I want to point out is the increased QT. Agranulocytosis is a medical emergency. People are very worried about that with the blood counts. Increased liver function test, lupus-like syndrome. So this is not a drug that you easily want to consider using as a first line. It does have active metabolite. It's less active, but nonetheless an active metabolite that can work. It's a very interesting metabolite because it actually has class 3 effects and not class 1A. It's called NAPA. Okay, and acetylprocainamide is the sort of a prodrug, or not prodrug, but it's a metabolized sort of active metabolite. It is renally eliminated overall for this agent, along with this hepatic metabolized agent, and so requires dosing adjustment and therapeutic monitoring of levels. And like I said, it's metabolized in liver, and then your active metabolites excrete renally, so it's double tricky. Okay, it can be toxic, especially with the NAPA levels, and the half-life is 3 to 4 hours, so we tend to run infusions, and onset of action is 30 to 40 minutes. ECG changes are listed there, and of course, everyone will be monitored if they're on antiarrhythmics in terms of ECG and blood pressures and vital signs. So it lands into a very valid drug to follow levels. Okay, there's enough justification for efficacy and especially toxicity, because you obviously don't want the active metabolite to accumulate and see some side effects before you start to think about drug levels. However, our lab doesn't have it in-house. A lot of these anti-arrhythmics agents, as you see in my slides, require external lab assay. We have to actually send it out of province. It takes about up to 3 or 4 days, depending on the day you send it, because they batched it. But the levels are there. So again, if it's a more chronic use with toxicity and efficacy, definitely will send it. But in my usual context in the ICU, it's a short term, hopefully. And so the value of sending blood levels to TDM might not be valid. So it's a very close monitoring and discussion with the team by the pharmacist, because by the time you send it back, the drug might have been discontinued or you're onto a different antiarrhythmics. But if it's anything looks like a long-term plan, you would consider monitoring efficacy ECG, your sort of vital signs, your telemetry. But for toxicity potential monitoring, it should be done, and especially if you're on it for more than a few days. So the level is published here. I don't expect you to remember it, but keep in mind, because NAPA is active metabolite, we look at procainamide target level, but the combined one as well, so that you're not thinking about the parent drug and not thinking about the active metabolite. Okay. So, keep these notes in mind, and you can come back, because I realize there's a lot of information download. So now, what about class 1B? There's still sodium channel blocker. They still block your phase 0, but it's little activity in atrial tissue. That means, for these indications listed, they're not being used. It's perhaps not the ideal agent for that. And it has the lowest amongst class 1A, 1B, and 1C. 1B has the lowest potency, the weakest blockade. Now, people may ask, then why do you even bother listing them? Well, there might be a chance where they can work synergistically, or because of side effects, you still use it. And it's very interesting. Mesillatine, we don't use as much because it's an oral structural analog. It means, an analog of lidocaine. The real point of discussion is lidocaine, which is available in different routes. It is mostly liver metabolized, and we usually do monitor TDM, okay, for reasons listed below. So liver dysfunction or severe heart failure may require lower doses because it's hepatic metabolized. Now, the hepatic dysfunction could be from the heart failure and backup of the perfusion and flow, in terms of the hepatic, circulation. So it impaired activities of the enzymes to break down lidocaine. So then you might have higher dose. Or the heart failure itself, because it's not being perfused the whole vital organs and other organs. So you're not really delivering the drug to liver to metabolize it. Now, only has IV form because it's very poor bioavailability, and it suppresses automaticity of conduction tissue by increasing electrical stimulation of the ventricle, his Purkinje tissues, and suppress spontaneous depolarization of ventricles during diastole. Indications are VTAC, VFib, PVCs. So that's why it's still listed in the American Heart Association circulation guidelines for eons, and including latest update. I sit on the research committee, and there's always constant debate. Is amiodarone better? Is lidocaine better? I think it's like a fashion trend. It depends on the update, and it's sort of head-to-head, because neither is the ideal drug, but they are good drugs for especially these life-threatening type of arrhythmias, okay? Again, it would be ideal if we have TDM in-house, but because of perhaps the infrequency of use, perhaps because of resource, we do not have that at this point. We do have a 1-week turnaround for those that are on lidocaine infusion, therapy longer time. We can send it to outside lab, and the target range is there. Okay, so I just want to let you know that. And before I go into 1C, if you are going to the resuscitation, indications and references, the latest update, which I think I included in the references, is the 2019 American Heart Association update on advanced ACLS, especially in general of drugs recommendation for both adults and children. So before, we would sort of upload amiodarone as sort of like a preferred first line, but the latest level of evidence, may not be randomized double-blind control trial, but the latest evidence that there might be a better patient clinical outcome of lidocaine versus amiodarone, but it's not really, equivalent in that sense, or one will replace the other. So they're both listed as options in the research guidelines. But certainly lidocaine has sort of crept up in terms of its popularity because of this latest update, okay? What about class 1C, okay? We talk about procainamide for one atypical poster drug, 1B, the procainamide, the lidocaine, and now class 1C. What are we talking about? Well, it's still block sodium channel, and it still slow down or block uptake in a phase 0. So it works similarly, but it's the strongest blockade of the whole class 1A, 1B, 1C comparison. And it's most potent antiarrhythmics, even though lidocaine is more commonly quoted and more quote-unquote popular. So it decreased the slope of phase 4 pacemaker cells, resulting in decreased automaticity. It has a mild prolongation of refractory period, but marked slowing of the intracardiac conduction. It still have negative inotropic effects, so you have to be very careful in your heart failure post-op cardiac kids. ECG changes are listed there. So what are we talking about? We're talking about flecainide. Okay, in the CARD trial, very, very, very long time ago with adults, there has been contraindications and concern about mortality. But in pediatrics, they are not little adults. They're different type of patients. So we find a place for flecainide. Indications are listed here, although SVT might not be the first line. It does have side effects: torsades, incessant SVT, bradycardia, heart block, AV node disturbance, decreased LV function, and also is oral. Okay, but it has found its place, and I'll tell you why later, with our cardiology patients, especially the patients where they came off ICU infusions, they're going on cardiology and preparing to go home. The contraindications, because of its pharmacological mechanism, is contraindicating second and third degree heart block and bundle branch block. So what about this drug? Let's learn about it. Liver metabolized through cytochrome P450, or most of the drugs are, especially in the antiarrhythmics arena. A lot of these drugs are going through the liver and metabolized by these enzymes. It actually means that you have to be very diligent to check drug-drug interactions and even sometimes drug-food interactions, mainly drug-drug interactions. And that's where a pharmacist can help you to look up current meds that you plan to add, and in terms of how they interact, will they interact? Does it mean you stop everything or one of them? Or do you reduce the dose, or do you do TDM, or all of the above? So drug-drug interactions is a very key point in monitoring antiarrhythmics in general, okay? Sex, race, and expression of these enzymes can, of course, affect flecainide serum concentration. In fact, the future should be pharmacokinetics, pharmacodynamics, and pharmacogenetics, sort of a triad, to look at these antiarrhythmics or any other drug, because any of those three mechanisms of phenomena will affect how the patients, being treated by these drugs. Milk and feeds can decrease absorption, and that might be a problem, especially in pediatrics and the young infant, where you cannot really host them to 3 meals a day, and in between, no milk, and you take flecainide. It's kind of difficult. So we try as a pharmacist to work with the team to make sure this effect is accounted for. Avoid concurrent administration of milk if possible. That means doesn't mean that you don't drink milk or you don't feed your baby with milk or dairy products. It's just that the timing has to be worked out with the family and the nursing staff. Okay, 3 to 5 days to steady state. And what do I mean by steady state? It is a kinetic concept. And if you want to go back to the high school calculus and work out the levels over time, you'll find that it depends on the half-life. If, say, for example, the children of flecainide who take the flecainide has 8 hours usually for half-life, it takes about 3 to 5 half-lives. So 8 times 5 is 40. So about 2.5 days or so to get steady state. If you have a shorter half-life, okay, then it will take faster to get steady state. Some drug like tobramycin, it takes 2 or 3 doses within a Q8 interval to get steady state. However, with flecainide, take a look. The half-life is 29 hours for neonates. Why? Probably because of the immaturity of the liver enzymes, because they're newborn. Plus, on top, you have a comorbidity with heart function, perfusion, heart failure. They might not deliver the drug through the blood to be, cleared by the liver that effective compared to older children. So they have 29 hours. So 3 to 5 half-life is like, 5 days plus. So again, depending on the population that you're looking at, and population, I don't mean like adults versus children, even within children. If you have a premature neonates versus a full-term neonates, again, that 29 hours might extend to even longer if it's premature babies. So you can see how we marry the effects and time to steady state. What does that mean as a pharmacist or as a clinician or nursing? It's okay, you start feeds, you increase feeds. It's a continuous feeds. Do I need to hold the feeds so that I can get the maximal or optimal absorption of flecainide? But if I hold the feeds, if it's a neonate, what about hypoglycemia? And okay, so now you tolerate feeds and you're preparing to go home and I put you on flecainide. Well, what do I do for the 3 to 5 days? Will the arrhythmias break through because you're not absorbing and getting to steady state yet? I don't really have easy turnaround TDM. It takes another week because external lab again. It has a wide therapeutic or monitoring range, but for your patient, they should be effective and no side effects at 200, but maybe another patient might be not effective even at you go for 500, but already have side effects that you have to limit the dose, but it's not effective. So again, the range is wide as a guide, but how you tailor to your neonates or infants and children, that's an art that we talk together as a team to find a plan for your patient. What about drug-drug interactions? It increased flecainide dose with amiodarone. And as you know, and maybe later on I can review that with you, amiodarone is a very tricky drug with prolonged half-life. So none of them will be steady state that soon. With flecainide, probably steady state sooner. So what do you do with the change in level? Do you do TDM? Because usually flecainide is a longer term. Or do you monitor side effects and also your efficacy by ECG? The patient's not having arrhythmias anymore, it's resolved. So these are aspects that you can read the chart or read my slides, but I just want to give you that context because I'm sure all of you can read Lexi or pediatric Lexi or UpToDate. But the point is that how do you integrate this information and translate into how to tailor it to your patient? I think that's hopefully the course will teach you that part to tailor, okay? So what about flecainide then? So usually it's not a drug that we would use in the ICU, but as they transition to tolerating food feeds, going up to cardiology ward, prepare for home, we will work with the team how to bridge that, how to ensure absorption best with the feeding patterns. Do we need to do TDM? Any drug-drug interactions? And when do I expect this to be sorted so that I can transfer the patient safely, stably upstairs, okay? Or 4D. 4D is upstairs to ICU. That's why I always call it upstairs. Anyway, what about another class in the class 1C that we have used or you've seen in the literature is propafenol. Okay, it's hard to access, but we do get access to it if it's sort of refractory. It has a wide range of indications as listed, but you also have a wide range of side effects, which is listed here. And so you can see it's pretty scary, cardiac arrest, sudden death. But these patients, remember, they are very, very closely monitored. And if the experts, which is electrophysiologists, that's not around, we'll always consult them with the ICU intensivist as a team, and we will go by the settings and how patients are doing. But at the same time, propafenol is not the first line. They probably will try other agents, and for those really difficult to control arrhythmias, refractory to other conventional agents or methods, they will go to propafenol. Now, the oral is 3 to 4 days. We do have an IV years ago, but we now have to go through special access, and I'm not even sure if you can get it fast enough. Extensive metabolized by liver, and again, this is this line. Apologies, it should belong to the procainamide slide, so I'll move that back and send it back to Cecilia for a reduced slide. So ignore this last. But propafenol is actually metabolized extensively by liver. So again, if you have liver perfusion issue or liver drug-drug interaction is something actually that you need to pay attention to and ask the pharmacist to help you. So I'll move this, delete this slide, move it back to the other slide. My apologies for that. So propafenol, IV is special access, so is PO tablets. Although PO tablets might be easier to get. IV loading doses as such and maintenance doses as such. Now, I didn't list the other doses in the other slides. This one is unique and it's a special access, so you might not easily find the information, so I put it there. And it's very tricky with compatibility too. It's only compatible in D5, so you can't really mix with saline, but a lot of the times our kids is on saline-containing solutions. So another aspect of this is a lot of the antiarrhythmics they're either poorly absorbed or acute situation-wise, you don't want to wait for oral absorption. They're on IV, and because of the short half-life in some, they're on IV infusion. But if you have incompatibilities like this example, you really have to access your pharmacist to work out which one is compatible where and how to run it effectively and administrate it to the patient. Okay. So we have case 1 here, a 32-year-old pregnant female, this is real cases, whose fetus has been diagnosed with SVT. She's now placed on digoxin for 2 weeks, but the fetus continues to have SVT. So what do you think is considered second-line treatment for fetal SVT? Now, I have no expert on how to deal with fetal SVT, but this is a sharing of cases that we have done before. And what do you think would be the sort of a second-line choice or a second choice in this regard? Do we open up or they will answer? Cecilia? Okay, we don't have a lot of time, but like if people know off the top of their head. I have these choices. It's important to give you multiple choices. Procainamide, lidocaine, and flecainide. Which one do you think?
Sotalol.
It's not one of the choices.
Oh.
Okay, good try. We can pass that later.
He's an expert.
All right. No, but
Oh,
Cecilia is
flecainide.
my prop. We have this role playing right now.
Is a flecainide answer?
Yes, flecainide is the answer. Reason is that procainamide has toxic metabolites as more side effects. Probably don't want to go through with the newborn, and or fetal SVT treatment because then, it's a lot to monitor as well as, potentially serious side effects that's probably more fragile in a neonates or fetus with the immature hepatic clearance. Now, lidocaine is more specific for ventricular tachyarrhythmias. That's why it's in a VT treatment categories, first choice with amiodarone in rhesus. So really not for this indication. So by ruling out, flecainide is and has been used for this indication to be effective second line. Now, why did you say that is second line? It's because it does have side effects, right? And it does require special treatment in terms of the feeding patterns and timing. So usually they use digoxin to sort of slow down the rate, okay? And if it failed, then we go for flecainide, okay?
So Winnie,
Yes.
In Brazil they don't have flecainide, so they use sotalol.
Oh, good. Okay. So the only thing is when we get to sotalol, there might be some side effects or monitoring that you need to do. Again, I don't think sotalol is wrong. I think that some things that we need to keep in mind is that as we have more experience with pediatrics and neonates, as people try different regimens, especially refractory cases in the neonates, you will find evidence, may not be randomized double-blind control trial, that they've tried it and worked. So although the classification and the common indications are being shared with the slide, keep an open mind that perhaps your electrophysiologist might have different experience and they may try it under intense monitoring to see if it works. Okay? So now what about class 2? Okay, class 2, they are actually beta blockers, okay, and they primarily work on pacemaker cells, and to me, it is related to heart rate, okay, because it blocks those receptors, it inhibits the catecholamines, the fight or flight stimulation, it decreases automaticity in the Purkinje fibers, increase refractory period in the AV node, and depress SA node automaticity. That's why it also slows down your heart rate. Okay, now there's beta 1 and the non-selective. Beta 1 is the one that's targeted to heart. How I remember, you probably do, is I only have one heart. If it's non-selective, it's beta 1 and beta 2. So beta 2 means lung. So it also affects lungs too. That's how my pharmacology professor teach me how to remember beta 1 versus beta 2. So esmolol, atenolol, metoprolol listed here, they are more specific to beta 1. So that works on the heart. The non-selective one, which means they have beta 1 and beta 2 properties that will also affect lung airways, is propranolol. Okay? Now we still use it, but just keep that in mind. Others are labetalol and carvedilol, which, we don't use it as much in the ICU setting. Okay? So a variety of indications, okay? But it might worsen heart failure, as we know, unless you use very small dose. And by that, if you use small dose, it's not going to be effective for your heart rate. And by extension of the pharmacology, it will be bradycardia, bronchospasm. Why is it bronchospasm? It's because, especially with the non-selective one, like the propranolol here, it also have actions on your airways. That's why it's contraindicated with your, asthmatic medications or asthmatic patients, for example. Hypertension, it changes your blood sugar, especially propranolol in neonates. We're trying to share our in-house experience for both CCCU and for when neonates start propranolol for this indication, a variety of indications, we have a informal protocol to monitor blood sugar with each dose and each feeds to make sure they don't drop the sugar. And it is significant and potentially clinically you require interventions. And, it's few, but then those are the at-risk patient neonates and young infants. ECG changes are listed there. So propranolol is what we typically use for oral transition. And I'll go to IV esmolol, so sort of reverse. When they can take PO and more stable, they take propranolol. Now, propranolol also have IV, but the dosing is very different, okay? I'm not asking you to check now, remember now, but you should check the doses. There's a big difference of IV compared to enteral. Because if you take a drug that is like propranolol through your gut system, what does happen? It's first past the liver. And liver is the organ that will chew it up and clear it. So I'm not even going to see much propranolol if you take it by mouth because the liver just sort of take a tax out of it. They just intervene and just pull it out of absorption, circulation. So very little is going to your systemic circulation to go to that site of action in your heart. But if you give it IV, you don't need the equivalent doses, much less. So it's very, very important to think about 10-fold or 100-fold errors in pediatric pharmacology and drug use, especially here, where IV and PO are so different. Most drugs, they're sort of similar, but these are the aspects you need to keep in mind. Half-life, 46 hours, so it's dosed more frequently. So for older teenagers, we might change to a longer acting, less frequent for compliance. It crosses blood-brain barrier, so it can cause nightmares, and it's hard to tell in your little ones. It is affecting both beta 1 and beta 2, but it also has been clinically studied in neonates and infants, so we feel comfortable to use it for SVT, okay? All right. Now, one thing important is for nursing staff and pharmacists too, and physicians is like if you have a asthmatic or some reactive airway history in your medication reconciliation and best possible medication history, or you just see puffers, okay, like fluticasone puffers or salbutamol puffers, you might question them. Do you have an reactive airways disease or asthma? Because if it affects the choice of antiarrhythmics, especially with beta blockers class, okay? So those are tips that you might or might not see in standard references, but that's just sharing my experiences. So beta-1 selective agents such as esmolol, I like that one because this is not enteral. It's IV, it's short on, fast acting, short off. If you have a side effects or heart rate problems, you can just fast on and fast off. We're talking about minutes, that's why it's infusion. And the only thing is, peripherally, you have to max out at 10 milligram per ml. If it's standard size, CVL, you could use up to 20 milligram per ml or undiluted. But the PIV will be needing a diluted product because it's quite irritating to the veins. So watch for inflammation of the veins, induration, phlebitis, and skin necrosis, heaven forbid, after extravasation. So it's an IV drug that's very easy to titrate because fast on and off, but you must watch out for your local sites if you're infusing through PIV. Okay, so if the asthma is able to do its rate control, then if they wean it off, they might then start propranolol. One common question is, when do I stop esmolol? When do I start propranolol? Do I overlap or not? Or any other beta blocker that's orally? It really depends on your indications and how stable the patient is. It sounds like a useless answer, but it's not. It's a negotiation with the antiarrhythmics team, like the EP team, the ICU team, and the 4D team. We typically, with first propranolol dose, we will reduce the esmolol for about half, and the second dose could be a quarter or off. But your patient will tell you from ECG, from heart rate, from your vital signs monitoring. So some case might actually overlap up to like a 4 doses period, which could be like, a day and a half. It also depends on current changes in terms of how they're doing with the blood pressure, the feeding. So with that, yes, you overlap, and yes, the titration schedule needs to be tailored to that particular patient. But the goal is to wean off esmolol, get to oral agents, and go upstairs to cardiology and go home. What about class 3 agents? Okay, it's a shorter class list. Potassium channel blockers. So remember sodium blockers in phase 1, the class 1, sorry, they work on phase 0. They are the fast-acting inpatient bunch. Here, the calcium channel blocker is a bit slower, not in the fact that it acts, but that it works later in the phase of the action potential, phase 3. It still prolongs refractory period through the potassium channel blockade. It still inhibits reentry and quite potent. Some agents can have mixed effects, including both potassium and sodium channel blockade, so prolonged refractory period and action potential. And what are we talking about? That's when we talk about sotalol and amiodarone. To me, I always think of amiodarone is my IV and I can change to oral. Sotalol is my oral agent to go home with. So those are the two choices, and they are broad spectrum. Just like meropenem and vancomycin are broad spectrum antibiotics for a variety of bacteria that might be sensitive, I see amiodarone and sotalol as a broad spectrum antiarrhythmics for the electrophysiologist to use. Okay, it has this unique niche, but it also has unique side effects, particular to amiodarone especially. So amiodarone, as I mentioned, is like a head-to-head with lidocaine in our research guidelines, particularly in control of refractory ventricular arrhythmias and prophylaxis against AFib, VTAC, and VFib. Sotalol, one of the audience mentioned they used it earlier. So we use that to treat a variety of tachyarrhythmias, and it delays AV repolarization, but it's not really a beta blocker, okay? It's a very mystery drug, even though it ends with talol. It's not necessarily a beta blocker in the sense we understand it from a previous class. So let's talk about amiodarone. So like this is like deeper dive. It has activity broad spectrum across 4 classes. I don't even know why they actually put it in class 3. Inhibits adrenergic stimulation, prolongs action through 1A, 3, 1, 2, 4. All of these classes action, it has some properties. It's vasodilatory though, and it decreases systemic vascular resistance, and has negative inotropic effects. Okay, and that has relevance later. Wait till the next slide. Indications are this variety that we talk about, again, bradycardia and 2nd and 3rd degree heart block. Okay, we need to, okay, maybe one more. Okay, so before we talk about kinetics, we have to monitor liver functions. Okay, maybe this is a giveaway anyway, so listed in that. So which do you think the organs is not affected by amiodarone in terms of side effects? Brain, eye, skin, thyroid, lungs, liver, kidneys? I guess I gave that away anyway. Hook the monitoring parameters. Anyone?
Brain.
Okay, all right. Any other answers? It's a very interesting drug. It has acute side effects, but it also has some long-term side effects. And it's fairly hard to manage. So let me open up the answers. It does affect the brain because it does cross brain barriers. It might cause nightmares, tiredness, malaise. It's hard because these patients are also heart failure patients. So it might not be hard, and plus they're pediatrics, they can't tell you. Eyes, most patients develop long-term corneal microdeposits, okay? Skin, they becomes like blue smurf syndrome, like they do tinge blue, long-term though. Thyroid, and that one is fairly recent onset, that means fast onset. So what we usually do is baseline thyroid function, whether it's on short-term, long-term, and in a critical care setting, it's worthwhile because It might be longer term. And also they may have a sick euthyroid syndrome that they might need some thyroid supplements anyway, or they come with thyroid background. So those are things that's why we have a baseline thyroid function. And then also the fact that, sometimes they have low cardiac output syndrome, you put them on steroid, vasopressin, everything, but they're still refractory. So you check the thyroid, they might need some sort of thyroid function replacement. So liver function, CNS side effects, so you march CNS, eye exam, chest x-ray, liver functions. So it's pretty broad spectrum in efficacy and toxicity too. Metabolized through the liver and gut, GI is checked. It takes 3 to 4 half-lives. So take a guess how long the half-life is. And if you read ahead the slides, you probably know already. So it's a month to 2. Okay, it's longer than digoxin. Okay, it's very, very long, which makes titration so much harder. Because yes, that means to get to a therapeutic range that will suppress or suppress arrhythmia, you need to give a loading dose just to get there. Just like phenobarbital for seizure, it's long half-life, you give a loading dose to get there. Doesn't mean it's steady state though. As the loading dose wears off, you might have breakthroughs and you might have to reload. You might not full load, but reload half dose until it kicks in with the infusion. Now to get to steady state, I told you 3 to 5 half-life. Well, 1 month is the half-life minimally, especially with neonates or younger children. And on top you have liver impairment because of high function or whatever. Then it might take you 3 months to get to steady state. So it's very hard to predict the side effects or the efficacy in 3 months' time because you're dealing with the moment. So usually because of the nature of the antiarrhythmics, you want an effect sooner. So you keep loading and loading and half loading and increasing infusion. At some point you have to realize it's going to come back and haunt you and accumulate. So that brings us to the fact that of all the antiarrhythmics, I would prefer to have amiodarone TDM, which we don't have, right? It's have to be sent externally, okay? Now it's hepatically metabolized, that's why the liver, but it also is interfere at the gut level with P-glycoprotein drug efflux. So they're sort of spitting amiodarone up, spit up. So that means it's hard to titrate oral dosing. Now when it does interact, it interacts a whole slew of things because it's metabolism in the liver. So we have some preemptively guidelines because you're not going to wait till the levels come up in 30 days to see what's going on for your digoxin. So we reduce empirically 50% digoxin and follow the digoxin level because even then it's long half-life. Within a week, you can do drug levels to see where things are. Or immediately, maybe within 24 hours after a loading dose, you can see where digoxin is. And then later on, once it's reached steady state in a week's time. Because you're not going to wait until amiodarone steady state to check digoxin amiodarone levels and interactions. Now, if you're warfarin, that's even more tricky because warfarin itself is hard to titrate with INR, and on top you're on amiodarone. So this is very challenging situation. So most likely is the electrophysiologist might not choose amiodarone unless they must, and then you will have to deal with all these drug-drug interactions as needed. Reduced phenytoin, although we don't use it as much in this population. Okay, so IV and loading dose. So loading dose you can do intravenous, most likely in the ICU when you're in acute situation, or oral loading dose sometimes with cardiology patients upstairs. The doses are listed there, and there's a loading dose phase for the oral one. Often though with the IV, because of acute situation, you might have to give a half load. So instead of 5 per kilo, you might do 1 to 2.5 per kilo per load and see what happened while the infusion is being jacked up to 5 to 10 or stay the same and see how the loads resolve the situation. Monitoring liver, thyroid, pulmonary fibrosis, corneal, dermal changes, those are longer term. Okay, so that's a broad spectrum one that's very tricky. So with TDM for amiodarone though, I find that to get the level, you'll take a week in the external lab. But it's still worth it, especially usually by the time they're on amiodarone, the electrophysiologists have think twice about it, and it's going to be probably they try everything else, and they will then monitor TDM, and it's within a week we'll know where it is. Let me share a story. It's recent, it's a real patient case. It's so refractory, it's a twin patient that is too early for surgery, like ablation or pacemaker. So we're using medication management. And we were on many things. I remember procainamide, lidocaine, amiodarone, asmolol. It's up there in my memory, and I've worked in this unit 25 years, not to show off, but just to tell you that in 25 years, I probably seen only this patient that is on so many concurrent antiarrhythmics and still could not control it. Eventually, we stabilized after many loading doses. I think I calculated over the few weeks in the ICU until we go to cardiology, almost 20, I think 25 loading doses and accumulative infusion doses for the cardiologist to would make reference. And I said, even though it's 1 week turnaround, we must do amiodarone levels, even if it comes back and it reflect like many days ago. Because if the level is high, by now, you know it's going to be higher once we get to 1 month or 2 months steady state. And lo and behold, the level is high. But because anytime we drop it, the level will not be adequate even though it's high to control the arrhythmias, and that's the only thing that seems to work for this patient. So we're waiting for time and growth for the next surgery, but in the meantime, knowing that we're probably using a higher than safe dose in terms of side effects, but we're monitoring closely, you can imagine. And unfortunately, I heard that there might be some side effects that I listed here that was sort of inexistent or after that initial phase. The patient's there, it's fine, but we are seeing some longer term side effects like the skin, like the eyes that we mentioned that unfortunately happened because that's probably the only drug that works in this patient. So these are real in pediatrics and depends on context. We need to be diligent in monitoring. And of course, the thyroid function, we were monitoring and supplementing. Okay. So sotalol, so another broad spectrum that's oral, and sometimes we do transition to amiodarone to sotalol for the long term because of those side effects. So beta 1 and beta 2 is beta blockade effects causing side effects, non-selective class 2, and it decreases the heart rate, AV nodal conduction. It also has class 3 effects like potassium channel, sorry, it's misspelled, channel blockade, increased atrial and ventricular action potential, ERP, atrial ventricular AV, SS3 pathway. But again, those side effects listed here are dose dependent. And because it's higher doses, it tends to exhibit class 3 agents, more properties from class 3. Dropping your blood pressure, dropping your heart rate, bronchospasm, as well as decreased heart function. So those are things that you don't want that in your patient. Torsades is a higher risk medication that causes torsades. Monitor to QC. So just for information, that's why cisapride, along with many other drugs with prolonged QT, is withdrawn from the market except for certain indications requiring approval. So what does that mean? Cisapride is not a QT agent for arrhythmias or antiarrhythmics. It's because a lot of these patients also have some gut motility issues from heart failure. So they might be on omeprazole, domperidone. If failed that, they need to grow, they need to feed. So we might have to consult GI and apply for cisapride. Then you have 2 QT prolongation agents that are high risk. So in this situation, it's very, very careful monitoring. So unfortunately, we don't use cisapride, but domperidone actually can increase your QT. So you have to make sure that baseline as well as continuous monitoring of QT interval is in place when they put in sotalol and domperidone together. Even on densitron, although our patient population are not on schedule IV and densitron, it also have a lot of different agents, prolonged QT, quetiapine. Some of our heart failure patients on LVAD or VAD, ventricular assist device, might need the delirium treatment of quetiapine to just sort of maintain until they bridge to heart transplant. So if they are on sotalol and another prolonged QT syndrome agent, such as quetiapine, we really have to talk. They need both drugs. So how are we going to try to find the best regimen? Okay, so those are things that where a pharmacist can help to discuss with the team. Now, yes.
Amy, so how do you advise administering the loading dose of amiodarone in infants?
Okay, so good question. Amiodarone actually is quite blood pressure sensitive in that it will drop your blood pressure. Okay, so for the neonates, what you do is neonates are not infused over an hour. Okay. Now, in the meantime, if you need a rate control agent, they might be loading on the digoxin. They might be on a beta blocker like esmolol, fast on, fast off. Usually, they don't like to use amio and esmolol together. They usually use amio and the digoxin. So the digoxin control your rate, and when you load the digoxin, it's relatively quickly that it will start, working in terms of slowing your heart rate. You might or might not have a pacemaker, but you still infuse amio over an hour. Infants not, and you can slow down the infusion. Okay, so you can slow it down, or you can give a half load over an hour and then another half load another hour. Now, the only exception though is that when it's resuscitation and you're using amiodarone, they have no return of spontaneous circulation yet. And so in that case, hypotension doesn't come into play. You want to rescue the patient, then you push the amiodarone loading dose. That's the exception that we are aware of. But for this indication of arrhythmias, and you haven't lost circulation, heaven forbid, then you will slowly infusion over an hour or longer. In the meantime, you use other agents or modalities to like either cooling with ice plus or minus the digoxin or other agents to slow down the rate. So that's why you obviously don't want a hypotensive patient on top of arrhythmic patients to be in this situation. Then you might have to shock the patient while they don't tolerate the amiodarone infusion. Does that answer your question? Yes, no?
Yes, thank you.
Oh, thank you. I can hear it. So all of you can actually send me questions after. I think it was very interactive last time, but this time I might need to go a little bit over if people can stay. But it's recorded for those of you who have stayed because this is a long chapter compared to last lecture, and I'm happy to take questions even offline through emails as well. No problem with that. Anyway, so class 3 agent sotalol, let's continue and see how we use it. To start, you might be more expert than I do in terms of detecting it. It's sort of a flip-flop pattern, as you can see. A sudden death up to 31 patients. The good thing is a lot of these high-risk patients will intensely monitor in AICU and 40 cardiology ward, and you should in your ward as well. Usually starting to 3 to 5 days. And that might be because as the sotalol kicks in and sort of have steady state or going over in terms of dosing, then you might actually see that side effect. So you must monitor for over 3 days, if not longer. And if the QT over 0.5 or QT corrected here, over 0.5, the drug should be stopped. Now, again, this is not in isolation. Hopefully, you have a team of electrophysiologists and cardiologists working with the ICU team to monitor these patients, 24/7, so to speak. So steady state is 2 to 3 days. That's why you see it's like usual onset when you have steady state 3 to 5 days. So it's sort of correlated to kinetics. Oral dosing is as such. Sometimes it helps to have the dose spread over to Q8, and so that they sort of don't have that high peak and low trough. And if needed, the dosage can be increasing gradually. Now, what do you mean by gradually? Well, look at this half-life, right? Excuse me. So 2 to 3 days. If you keep increasing without being patience to look into the steady state, you could be overshooting in 2 or 3 days and you really have the side effects that mentioned or torsade. That's why we take 2 to 3 days to see how the patient is doing, no side effects that you can observe, then we go up on the next step, especially with the neonates or the medically fragile cardiology patients. Okay, so case 2, okay? I still want to go through the case. 3 kilo, 12-day-old boy, neonate. I didn't tell you term or no preterm. Anyway, so just pretend it's a full term. Sent home after cardioversion for SVT. He returns to the hospital with SVT and decreased heart function. Initially, they put him on procainum infusion. Well, you can't really go home on that. So you switch to oral propranolol. Well, it breaks through. Then you try flecainide, either feeds or fail the Y study. So what do you use next? Hey, what do you think? What do you use? Any attempt? Would you use amiodarone or sotalol?
Amiodarone.
Okay. Now, it's not wrong. The model answer is actually sotalol, but I know what you mean because I've seen both. Only thing is amiodarone is such a long half-life. Okay, you're gonna have to keep the baby boy to do oral or IV load of amiodarone and infusion. Then it's sort of a long term. Sometimes they outgrow it later, but you don't want to put a neonates with liver impairment from heart function and impairment from prematurity or even maturity as a neonate. So what they would attempt probably is sotalol first, okay? Because it's oral, it's relatively, perceived or perhaps safer than the long-term amiodarone. And you don't have to keep them so long to IV load them. So they try sotalol, but again, depends on your center, your comfort level. Amiodarone is not wrong, so I don't want people to judge that. It's just that for our center, they choose sotalol in this case. So again, you allow the 3 days to stabilize before you go up on the dose. And pharmacists will have a big role in helping you to counsel the parents about how to give it. So those are the questions. I think in the slide deck, I can provide the model answers later, okay? So change the so on day 18, ECG find max dose, QC go. Now, the QC prolongation, it's a problem. 11.43 corrected to 0.57. So we have to stop it, okay? So what would you do? Then you have amiodarone. So it's like one way or the other. The side effects might even dictate your choice rather than efficacy. A lot of these situations with solo amiodarone, it's not that it doesn't work. It works very well. So broad. But your side effects is going to be your deciding factor for your patient. Okay? So class 4. Okay, we're almost there. Okay? It's listed here. It's not very commonly used. I have to tell you, rapamycin, we don't even order it. But for comprehensiveness, and depends on your center, those are the out of the calcium channel blockers, and we know that we have nifedipine, we have other agents, but these two are the ones that has IV form and oral form that we could use. It slows down the calcium blockade, or the calcium channel, and so it decreased the no automaticity, the conductivity, and it's used to treat and prevent atrial arrhythmias. It's more focused on that and control the ventricular response rate. The contraindications, though, are with Parkinson's syndrome, the WPW, may induce fatal arrhythmia, tachycardia in some case reports, VT, heart block, infants, so neonates, we don't use it, or even young infants, we don't use it, and may cause cardiovascular collapse. So that's why with all these contraindications, and sometimes you don't really know initially with the patients what's going on, our team tends to avoid or don't even use calcium channel blockers, but we want to include it for your own references. Okay, so the information is there. I'm not going to spend too much time on it. So another case, okay? So what happened here is a case of, an older boy now, 5 years old, Epstein, dilated R atrium, already the left function, ejection fraction is reduced 42%, not too bad, but it's reduced. He has atrial flutter with the heart rate of quite high, 220. What is a good IV medication to control the heart rate? Would you use class 4 agent, diltiazem, esmolol, class 2? Okay. And what about propafenone, class 1C?
Propafenone. And
Yes.
somebody said esmolol too.
You know what? Propafenone could be used, but it's not first line because of proarrhythmias, okay? And it's special access in our country. So by the time you get it, it could be tomorrow or even worse. So that's just practically the practical reason, okay? And from my experience, I would have used esmolol. Beta blocker or calcium channel blocker in itself, in general, is contrary to heart failure patients. And here you have 42% ejection fraction. I have seen using esmolol because it's fast on and fast off. So even if you reduce the heart function and drifting, then you can stop it. The diltiazem is longer half-life, and we're less familiar using it. It's not wrong. You can use it, depends on center. But I can tell you esmolol is probably our go-to agent in this case because of the relatively titratable and short half-life, sorry.
Tammy said they use esmolol at CHIO in Ottawa as well.
Yes, good. All right, because I mean, I think that we have more commonalities than what we think we have in terms of antiarrhythmics, despite the messiness of the mechanism. So what about case 3 continue? So this patient has atrial flutter, has returned on the medication previously ordered, so we need a new agent. So we said like it's amiodarone now, because if it still persists and you still have heart failure issues, then you might be left with nothing except amiodarone. And then in itself, you have to manage any drug-drug interactions. If this patient, remember, is a heart failure patients, they might be on anticoagulant, warfarin or perhaps other agents. So you have to check in interaction, especially if they're on warfarin. But you have also other agents now in terms of decreased heart function and anticoagulation that might be perhaps safer in the context of drug-drug interactions. Okay? So okay, we talk about that. Now, additional agents. We can finally come to our last class, okay, of drugs. These doesn't belong to any of the class and has unique roles in its own place. Digoxin, adenosine, magnesium, and dexmedetomidine, which is a new agent we add since our last lectures from previous course. Okay. So dexmedetomidine is the newest kit on the block. It's usually used for sedation and analgesic properties. It's like alpha-2 adrenal receptor agonist. I imagine this drug as an IV clonidine. Like clonidine is oral right now. There's an IV special access, but it's the IV sort of sibling that we can use in acute setting or ICU setting. We managed to discover that not only does it do sedative and analgesic properties pretty well, but it can also manage SVT and VT. Adjunct to more traditional therapies, we don't start dexmedetomidine for this sole purpose, but if they happen to be on dexmedetomidine for sedation and analgesic property, opioid sparing, you can expect some management of SVT and VT efficacy here. And our range is 0.6 to 1.5, so you can titrate for that property. Although for sedation, we have escalated up to 2 for sedation, but not for antiarrhythmic effects. Increase vagal nerve activity, it slows down your heart rate. We've seen that with bradycardias, with dexmedetomidine for non-arrhythmias indication patients. Okay, so I added that. So what about back to our own other list, which is digoxin? We use it for heart failure. We use it for arrhythmias to slow down the heart rate. Very complicated mechanism. I think that if I really have to spend time telling you how it works, it's probably in our pharmacology textbook's entire chapter of how it works because it's very, very complex. But I list the key ones here: prolonged ERP of AV node, slow down conduction. So to me, if I think about it, is while your broad spectrum is kicking into place like amiodarone or sotalol, especially amiodarone, I need a rate control agent, and digoxin is a good one. Not only does it help with heart failure, it actually slows down the rate, and it works because of the loading dose, because it's IV. It's a very old drug, but it works. It's very reliable. Slow ventricular rate, and the side effects are there. You can monitor it. If you have renal problem, you need to probably do TDM. The good thing is the digoxin TDM is in-house. You can get it post-load. Usually we give some hours, 12 to 24 hours for it to distribute very slowly so that you're not getting a sky-high level for contamination or sort of not finishing distribution. And then you can do it, at 3 or 5 days when it expect to get to steady state. It's fast assay, right away. So I think that it probably has more bad press because of the past history where some neonates in some old literature, and actually it's the kids that when they were receiving digoxin, they have passed away. Perhaps many confounders with the arrhythmias, with the prematurity. In fact, it launched our therapeutic drug monitoring program and unit dose system at sick kids because of that, unfortunate history. But we now know how to use it with TDM, with its place in therapy better defined, and with the whole team of monitoring. It works. It just slows down your heart rate until your amiodarone kicks in. Show you the kinetics information here, long half-life, especially neonates, premature neonates. Because it's cleared both liver and renal, especially renal, we have to adjust. And all these long-acting agents is a nightmare to monitor drug-drug interactions because you actually don't know when it starts, how long it starts, when does it peak, and when I stop it, how long it lasts, because it depends on the half-life of the drug. So many drug-drug interactions, I would think that anytime you see these antiarrhythmics, it's a good idea to consult your pharmacist or check drug interactions, even if it's a preliminary check with your, say, online Lexi interactions, because it's full of it, from antibiotics, antiarrhythmics, agents that you might not even think about. So you need to check on that before we sort of, continue on a therapy. Okay. Sometimes people don't think about long-term drug interactions because at the time you need to treat the patient acutely, sort of manage them, and then you think about the long-term plan later, and that's when you need to think about toxicities. They might require dosing adjustment and TDM. Now, because the digoxin has side effects and affect potassium levels or require proper electrolytes levels to make it work, calcium, magnesium, sodium, potassium, all those electrolytes has to be corrected and maintained so that they work optimally without side effects. So obviously ECG, heart rate. Okay, well, after all, you want to slow down the heart rate. So it makes sense that you're monitoring anyway. Now, because it's so long half-life, like any long half-life drug, you need a loading doses, not to get to steady state faster. Don't get me wrong on that. Steady state, you will still take 3 to 5 half-life. It's just until the level builds up to where you want it to be, you give a loading dose so that it can sort of top up and get that level now and works efficacy. And then as it comes off that loading dose, your maintenance infusion now build up to steady state, and the combined level will be where you want it to be. That's how we use loading dose. Then you're going to say, well, most loading dose like amiodarone is like one-shot deal. You might infuse over an hour, but it's one loading dose, that's it. If it breaks through, then you give a half a loading dose. But here, why do I want a total dose but still split in 3? The reason being is that it takes 6 hours for the first dose. The digoxin likes to go to the heart. Then it distributes. And if you have heart failure or premature neonates, it distributes slower. So before I even have time to deal with my first loading dose, you give me another, and it just overwhelms the system. I have sky high level, I can't distribute the goods yet, so that you see the slow down heart rate, heart block, side effects, toxicity, then that's no good. So every 6 hours, you give the second half and the third half. Now, some institution will do half, quarter, quarter. That means half, you get there halfway, then quarter, quarter. I'm not debating right or wrong. There's no right or wrong. I choose, and I did choose here, and the EPE team accepted, half, one-third, 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 because if pharmacy send out 3 doses, the nurse can pick any one of those 3 and still get the right dose. If I send you the half dose and the quarter, even though by volume you can tell the difference in volume, but in a tiny little syringe in the middle of the night and the lighting might not be great, you might just pick the wrong one. Now, if you pick the quarter, that's okay. It's just that it takes you so long to get to effects. If you take the half, that's good because that's what you want. But you don't want that potential error. Now, some of you might have bar coding, but still, if kinetically doesn't matter, I'd rather do one-third, one-third, one-third. And you see the EP team actually might decide not to give the digoxin second or third loading dose because by now amiodarone kicks in. It works. They converted, they're fine. So when it breaks through again, then they might give the second loading dose or the third, and then they might then decide maintenance or not. So don't be too critical of your team. Well, the reference says 3 loading dose and a maintenance. Why are we not on that? Well, it depends. They might be waiting for it to kick in, see if amiodarone is going up or not, and see what other concurrent situations going on. Now, this one is not one-to-one dosing. Remember, propranolol is the sky-high oral dose, but tiny IV dose because of hepatic first pass. Here, the IV to PO is 0.7. That means IV dose is more potent. So when you actually go for oral dose, you have to convert by 0.7. Okay? So if you're lost with the conversion, call your pharmacist, or there's online reference, and they can help you. Digibind is if you go overdose for whatever reason, you can have this antibody to bind the digoxin to treat life-threatening digoxin toxicity. In most likelihood, though, it's usually elevated levels and it's renal impairment, and we let it drift down with time and hold the doses. But if you need this digoxin antibody, we can order it. We don't have it in-house. It's so expensive, but we have a local Toronto depot that can ship to us, or we have 1 or 2 vials in surrounding hospital or within us. However, when you're in Digibind, you must tell your lab, because if you're high level, you're probably going to do TDM, drug level. But the antibody will interview assay. So they need to change to a mass spec or HPLC assay, and your lab biochemist and your TDM pharmacist should know about it and will account for that. So for days, they will not be able to do a routine digoxin level. They have to do the mass spec, which is based on mass of digoxin and will not be interfered by the antibody present with the antidote treatment or the HPLC, liquid chromatography, that's specific for that peak in the chromatography. Okay, so adenosine. This is a very interesting drug. It's probably the shortest half-life drug that I ever know at this point. Onset is only seconds, 7 to 10 seconds. Rapid IV bolus is required over 1 to 2 seconds because it's such a trick. It is inactivated and metabolized in the blood. Even if your circulation is quick, if you administer very far away from the heart, you have heart failure or low cardiac output syndrome and the perfusion is sluggish, it takes forever to get to your heart, it'll be clear before you can even get it. So that's why it's escalating dose and it's fast push. And I don't know the nursing techniques. If you're interested, Cecilia knows how to give it closest and fastest with a flush. If you don't follow with flush, it could be sitting in the tubing in the hub, and then you think that it's not working, or you might come to the wrong decision or conclusion. You need the adenosine to be given fast, given close, and with a flush. Okay? Side effects are here, but the good thing is it's so short acting. By the time you notice it's done, causes end up feeling dependent relaxation of smooth vessels. So you might have chest pain, flushing, hypotension, bronchospasm, and AF, Y complex. All these listed things. The good thing is it lasts very short. Contraindications, second and third heart block. And before I go, I'm not the expert on diagnosis. Because it's so short acting, it can actually serve as a diagnostic agent. They might do first dose, then double the second dose, and then triple the third dose. And in our resuscitation guidelines, we have dosing guidelines there. But they might unmask certain pathway in the heart and allow the electrophysiologist to find out what type of arrhythmia this is. So when the time comes, you might want to ask the other lecturers coming up the thought about adenosine and why they would use and when they will use it as a diagnostic agent. Even as a treatment agent, it doesn't last long. So you must think quick while it's working to say, am I starting amiodarone, esmolol, digoxin, so that it can just sort of give you the moment to think more and then top up with another agent to last longer. Magnesium, we don't use it that often as antiarrhythmics, but there's two purposes. As the electrolytes to normalize so that hopefully your heart is not subject to all these electrolytes abnormalities, because after all, the action potential is about flow of lights across the membrane. So you want to make sure that they have a good start with normal lights level. Second, remember the Tassard, and the digoxin and other antiarrhythmics require magnesium to be normal to not have side effects. So if you have Torsard, and in our crash cart, we have magnesium to treat it. Okay, that's the effective agent. It interferes with the calcium transfer, so you're not firing it off, and reduce heart rate at a high dose. But the fact is, you might have to slow down infusion because it does drop your blood pressure. Remember, for those of you who work in med-surg as well, magnesium sulfate is an infusion that will bronchodilate. So when we use it for bronchodilation, we also have to slow down the rate so that it doesn't drop your blood pressure. Imagine you have an asthma patient needing it for status asthmaticus, and then you drop your heart rate and drop your blood pressure with magnesium. That's not very good with that. So that's why it's a mechanism that you have to check the dose. It's a highly concentrated electrolytes, and make sure that infusion is also slowed down with the keeping in mind the blood pressure. Okay, we are getting to the last slide. Case 3. 6 months later, the baby AK came back. Yes, they finally grow big enough to ablate the accessory pathway. His amiodarone is stopped. So you want to put him back in the digoxin. Would you start the full dose? 1, would you load? How many loads would you load? Or no load, and what would you start? Full dose? Or would you reduce the maintenance dose? And why? Any answers? That's your last case before you can be released. Any answers? Or they're offline now?
No, they're there.
Sorry, my screen doesn't see questions. Cecilia,
The only question that was remaining on the screen was adult ICU do use adenosine to slow the rates to determine the rhythm. So that might be like accessory pathways.
Yeah, so I mean, we do that too, but then we might not give multiple dose, by then we hopefully do something.
Okay, so we have an answer of 50% of the dose.
Yes, so the answer is actually you need to reduce the dose. Now, how much? You said 50%, and I would do the same thing as a pharmacist because amiodarone is long half-life. You stop it, it won't come out completely of system until 5 half-life. It could be like 10 months, or at best 5 months, because the half-life is 1 month, 30 days to 60 days. Mm-hmm. So in the meantime, as it gradually reduces the influence of interaction of digoxin and other drugs, you have to monitor digoxin level. Now, because it's for heart failure, you're not in a rush to use digoxin, it's not arrhythmias. Often they also use lower dose to start with. We tend to use higher digoxin dose to get a higher digoxin target level. It's still within the range, but higher end to control arrhythmias. That's my experience. It needs more within the target range. So it is 1.5 to 2.5. I tend to drive it up to 2.5 to get the rate control. If it's heart failure, tiny little bit, they don't even bother with levels. So that means you don't need full dose. You don't even need 50%. Maybe you can titrate to response because this patient might be on beta blocker by then. Maybe 1/3 of the dose. Now, again, this is not a hard and fast rule because 50 or 30%, hopefully you'll be checking a level in 5 days. Not because heart failure. If the patient has no arrhythmia, clean in terms of no arrhythmics, no amiodarone, you would still not start full dose of digoxin, usually lower dose, just like your beta blocker in heart failure, low dose enough that they don't even check with, TDM because the renal function was fine. Here, because of the amiodarone influences, you will check a level to make sure it's not overshooting. And then over time, you might have to check it again as amiodarone get out of your system. And also see if 30% or 50% is enough for heart failure, but not too much to give you bradycardia and all these side effects. So yes, correct, thank you, good job. But 50 or 30% might be some sort of soft reduction to discuss with the team, the plan, and going forward. So I don't usually argue about, the reference formulary said at sick kids you should do 50%. It is conversation, is a guide. So with that, thank you for your attention. I'm sorry it went over time because I really did want to include some of the updates. These are the references. Now, although they're not that update like 2020, October, but those are the reference I reviewed that I think will help you. The general is more adults, and it's a good review. It's like, 200 pages long, but you can sort of search the points and they have a good review there. And it's constantly being updated, Cochrane Review. Pediatrics, I find a MOFIT, which I base a lot of these talks and information very relevant, especially if you're sort of a practical pharmacology perspective. And that 2014, although data, that Pediatric Cardiac Intensive Care Society consensus statement has a lot of series, not only on antiarrhythmics, but post-op cardiac care in terms of drugs. And then I also have this AHA guidelines with updates and acknowledgement. So again, because of time, I can answer the questions afterwards as well through Cecilia, or you can email me. It's winnie.cito@sickkids.ca, or if you're working at Sick Kids, you can come in and we'll interact at bedside and I answer your question. Any questions right now?
We have one last one, which was about metoprolol as an antiarrhythmic.
Now, I have to be honest, we don't tend to go with metoprolol. Probably because we have younger kids and we like the titratability and shorter acting to titrate with propranolol. I think that with the metoprolol, though, we do have older kids, and from other centers that they come when you do your MET-REC, like they are metoprolol. Well, we're not stopping it because obviously the patient has been stabilized on it. But if you ask our team, we just feel like with the metoprolol, I'm just going back to class 2 agents, that it tends to be so long acting that you're not nimble if they have side effects. And, first of all, you transition IV esmolol. So we wanted to have that in terms of that titratability, and propranolol is sort of like, although it's non-selective, is shorter acting. It is beta-1 selective, so theoretically, but the dosing is longer acting. Although its compliance is good for older kids, we just rather buy the convenience of propranolol of short acting that we can just sort of stop. And maybe it's particular, like experience and context of our team here. So it's not right or wrong. We've used metoprolol in older kids and transition them, no problem. It's just the dosing and the practicality of propranolol for younger children. Okay?
Okay. Thank you, Winnie, so much. That was incredibly informative.
Thank you. Appreciate it.
Yeah.
Okay. My pleasure.
So everyone, I just wanted to remind you, I know I did send out the email just a day or two ago, that we have put all of the presentations, everybody's name in there somewhere, so if you can check it. Also, we did do a few adjustments, so please, if you can check it today. And if anyone has any questions or you're having trouble getting into accessing the videos or the presentations, please just let Carrie and I know, and we will resend the link to you. Or if your link gets lost, we can resend it again. All right, any last questions, comments? All right, thank you. Have a good weekend, everyone.
I'm trying to clean this up. What else do you need to clean? Just toothpaste. And the keyboard. I think the keyboard you need to wipe it. How many students do you have? Do you want to half the